Hello and welcome to this session of Surgery Online. My name is Magdalena Schweißgut and I am a product manager for middle ear implants at MED-EL headquarters in Innsbruck. And it will be my pleasure to guide you through this session today. So we have prepared a few highlights for you. Well, first of all, we are joined by an excellent speaker, Professor Dr. Lukas Anschütz from Lausanne in Switzerland, and I will introduce him in a little bit more detail in just a moment. And secondly, he will present for you a very relevant topic of modern otologic surgery, namely on endoscopic Stapes surgery. So very interesting. And last but not least, he will show us this procedure using the mWING Stapes prosthesis, so one of the latest Stapes prostheses offered by MED-EL. So this is, of course, very exciting also for me as the product manager. And I think considering these three highlights, it is no wonder that I'm very much looking forward to this session today. All right, during this session, feel free to type all your questions and comments in the chat. We will have a some dedicated time at the end of the session to go through all the questions and have a lively discussion with all of you. All right, now, before we jump into the topic, I would just take a brief moment to introduce to you the mWING Stapes prosthesis so that you know what makes this prosthesis so special. So here you see on the picture that this prosthesis is actually a combination of a wide loop and a slim loop. So this might seem like a contradiction, but it's actually not. And both concepts have their advantages. So the slim perforated loop in the center optimizes the alignment between the long process of the incus, the prosthesis, and the Stapes footplate. So after crimping, the piston is less likely to tilt, so that a perpendicular angle to the footplate is easier reachable with this prosthesis. Now, on the other side, we have these two pairs of wings that enlarge the contact surface to the incus and make a stable placement and crimping process possible. So these are the main features of these prosthesis that I wanted to share with you before we see the prosthesis being placed by Professor Anschütz during the procedure. Okay. So now I would like to introduce to you Professor Dr. Lukas Anschütz. He is a, just quickly, yeah, okay, there it is. So Professor Anschütz is the head of otology and neurotology at the University Hospital of Lausanne in Switzerland. He is also an associate professor at the University of Lausanne. His research focus lies in advanced imaging methodologies, endoscopic anatomy of the middle ear, surgical technical developments, and also improving teaching methodologies for medical students and future ear surgeons. So a very widespread field of interests, and I'm very, very happy to have Lukas Anschütz here with us today. And with this, I'm also at the end of my introduction, and I would hand it over to Lukas Anschütz. Lukas, can you hear us? Can you see us?
Hi. Hi, yes, I can hear you very well. Can you hear me as well?
Yes, it's perfect.
Fantastic. Thank you very much for this very kind introduction. And I prepared a few slides to share with you. I will do that now. And so we can talk about endoscopic stapedotomy and in more detail about this very exciting new prosthesis, the mWING. I prepared first a few general considerations about endoscopic Stapes surgery, endoscopic surgery in general, because I think this is still a topic which deserves some more attention. And then we can have a closer look at the use of the mWING prosthesis. So let's start right away. For those who are not so familiar with otosclerosis and the ear surgery in general, I just prepared a few general information about otosclerosis. So it's a disease of the otic capsule. And you can see it here on this, this figure. You see here this bone disease, which fixes the stapes, and in more detail, the footplate at its anterior part into the otic capsule at the level of the oval window. It's quite something quite frequent. So it's around 1% of the population who is concerned by otosclerosis, and women are more often have more often otosclerosis than males. Sorry. And the etiology is largely unknown. There is a hereditary component in about half of our patients, but you might all know these patients who don't have positive familial anamnesis. Usually, its manifestation is in the young adulthood. We know that in pregnancy, there is usually a boost of the disease severity, but it can also be later on and quite uncommon, but also possible in children. So the symptoms are slowly progressive conductive hearing loss. You can see here an audiogram with a typical manifestation of otosclerosis. You have the conductive hearing loss, especially in the lower frequencies. You have also a sensory neural component, usually at 2 kilohertz. It's called the Carhart notch, and then again in the higher frequencies. There are also some forms with progressive sensory neural hearing loss. There is some cochlear otosclerosis, but these are special cases and it's much less common. For a diagnostic workup, I usually perform a pure tone audiometry, tympanometry, and Stapes reflexes are recommended. And this is a bit a matter of debate, but I usually perform a CT scan to rule out other causes of conductive hearing loss with a normal eardrum. Of course, history taking and clinical examination is very important in these patients as well. Regarding treatment, either you can adapt a hearing aid for these patients, or we propose a surgery. I usually give both options to the patients, and so they can decide themselves. But of course, today we will talk mainly about the surgery. So Stapes surgery has been described a long time ago, and usually it's a procedure which is performed by the microscope. Already quite early on, Stapes surgery has been performed. And if you look into the literature, the endoscopic approach is much more recent. I think in the last 20 to 30 years, it has been really applied a lot. And if we look into the literature, this is a very a meta-analysis which is from 2026, so a very recent study showing that endoscopic Stapes surgery or microscopic Stapes surgery provide almost the same outcomes regarding the hearing. It's not something which is really astonishing because we are treating the same disease, and so hearing outcome, which are usually very good, are the same in both techniques. However, we see that there is a reduced chorda tympani nerve manipulation and less dysgeusia in the endoscopic approach, and also there is less need to remove bone of the scutum or even perform canaloplasty in order to achieve or in order to reach the middle ear and in order to perform the surgery in good security. So these findings, and I would say this is a cumulative experience of the last years, really support the endoscopic Stapes surgery as a good alternative to microscopic Stapes surgery, or we can say it's more or less the same for both techniques. Remember that endoscopic ear surgery by itself is not really a different surgical approach, but it is a different technology in order to see good what you are doing. So I like this citation a lot because the secret of change, so in this time is the change from a traditional microscopic approach to an endoscopic approach, is not to focus your energy on fighting the old, but on building the new. And this is what we were doing the last couple of years in order to spread a little bit the endoscopic approach. So the transcanal access to the middle ear is a typical approach which is chosen by the endoscope. So we use the external auditory canal to reach the middle ear. It gives you a direct access, especially to the attic. You can see it here on this CT scan. You see here the attic. It gives you a natural route, so you don't need any incision, and it's only minimal bone work required to go to the middle ear and to do your work. So we can consider this kind of approach as minimally invasive. You might say many surgeons can perform staple surgery also in a transcanal way. I was also trained like this. And I think this is something which is absolutely true. And we can talk about this in a short time. So if we have this picture, this is a picture from my holidays in the Abruzzo Mountains in Italy. You can see through this stone window, you can see this small building. We might say it's a Stapes. We can see it very, very well. But we cannot really see what is around because this bone window takes away some of the view of the landscape. When we put our head through this window, you can then all of a sudden see, okay, we are standing on a very nice castle. There are a lot of mountains behind, and we still see our small church in a very, very good way. So this is illustrative for the difference between the microscopic approach. Here you can see we look through the canal and we see very well, but we see only a part of the middle ear. And this is something, of course, in stapes surgery, we have no disease in the middle ear. There is no cholesteatoma, there is no bony erosion usually. We want to see the stapes, we want to see the footplate, and this gives us a very nice view of the region of interest. The endoscope is different. We put our endoscope inside the middle ear or inside the canal, and we have a wide-angled view, so we don't see just the stapes, but we see all of the middle ear at the same time. So what are the challenges in endoscopic ear surgery? So if you are this guy, perhaps you know him, and with your endoscope in your hand, very keen to start, then your enemy, I would say the main enemy, is this guy. You might know him as well. And of course, it's represented by the external auditory canal. And it's quite similar also if you want to do a transcanal approach with the microscope. Because if you have an external auditory canal which looks like that, for instance, or which is very, very curved like this one, it will be very difficult to reach the middle ear. So we have to take into consideration a few things. If I will show you a video. You see, it's not about otosclerosis, but about another pathology here, a chronic middle ear disease. And you can see if we want to work here through all this hair and through all the dirt in this canal, it will be very, very difficult. So the first thing, if you are handling your external auditory canal in an endoscopic approach, and this might be very different from your microscopic approach, is we need to prepare this canal. We need to make it clean because we have to work around it all the time. So you see my hairdresser skills. I need to cut here these hairs in the external auditory canal in order to have a clean field throughout the surgery. And then, and this is particularly important also for stapes surgery, we want to wash thoroughly the canal. We want to have a very clean field in order to have a good view throughout our surgery. This will take you perhaps 2 or 3 minutes in the beginning of the surgery, and my scrub nurse tend to make fun of me during this time. But I think it's worth it. You will win like 20 minutes in the end of the surgery when you prepare well your canal. So what are the other challenges in the endoscopic approach? So the size of the auditory and the external auditory canal is very, very important. We usually use a bit thinner endoscopes and shorter ones compared to the endonasal approach. It's very important to set your light source at only 50%. If you put it too high, you may have a heating of the middle ear, which may damage your inner ear. And prepare the end and the canal, and then it's a one-handed surgery basically. So you need to consider your learning curve. You need to have proper training, and you need to be able to manage the bleeding. So management of bleeding in endoscopic ear surgery, I would say, is a central topic, especially if you want to start with endoscopic surgery. So it's important to infiltrate some adrenaline or diluted adrenaline. I usually infiltrate around the ear and also in the canal. We can use topical adrenaline on neuropathies. Here you see it's a very high concentration. It's how it comes out of the syringe. It's pure adrenaline, and you need to have a controlled hypotension. It's very similar to the microscopic approach as well. So you want to have, if you have higher blood pressure and also beats per minute, the heart rate, you will have more bleeding in your surgical field. And then we have some ideas. We can use monopolar cautery to mitigate the bleeding. It's important if you use monopolar to use it at very low intensity, because otherwise you might have a spread of the electricity to the facial nerve. And I will talk about the dotted line just in a second. And if you have one bleeding spot, of course, you can also use bipolar cautery in the external auditory canal. So this is just a very small video of a cholesteatoma case. You can see the infiltration with adrenaline. Everything gets very nicely white. And then we can do our tympanomeatal flap. You can see here the dotted line performed with the monopolar cautery. You see, I just do a small point. I apply a bit of energy to the tissues so that they stop to bleed when I start the surgery afterwards. If you apply too much energy, you will have a shrinking of the flap, which will not be good for your closing at the end of the surgery. After the dotted line incision, we can then use a cold instrument to complete the incisions. And then we elevate our tympanomeatal flap in a very standard way. You can see I'm using here these adrenaline-soaked neuropathies, not only to control the bleeding, but also to dissect. And you can see virtually there is no bleeding here, at least on this video. And like this, you can work quite quickly also when using just one hand. And here we go into the middle ear. So this is something very important for you, especially when you consider to start your journey about endoscopic surgery. It's very important to choose the right case in the beginning. And I love this diagram. It's very, very simple. It's also very old. You see it's from the 60s. And the green ring or the green circle is what you can do. And the blue one is what you cannot. So in the green and in the blue is important. It's impossible to learn something because or you cannot or you can already do it. So it's the region in between. It's the purple ring. It's what you can do with help, and it's called the zone of proximal development. So this is something very important to consider, not to start with a too difficult case in the beginning. And I would say stapedotomy is really the last thing you want to start when you're doing endoscopic surgery, especially, or even if you already have some experience with microscopic surgery, even if you are a very skilled surgeon, it will be difficult if you start off your journey in the endoscopic technique using a Stapes surgery in the beginning. I would really advise to do this in the end. And our colleagues from Italy, they have developed this diagram. You can see the different levels of difficulty. Level 1 is the canal and the eardrum, grommet insertions, some easy things in the external canal. 2 and 3 is the middle ear, and 4 is inner ear, and 5 is the lateral skull base with the endoscopic approach. And I would really say 2 is perhaps a type 1 tympanoplasty, and 3 is then cholesteatoma, and let's say 3B would be Stapes surgery. It's really important that you know that the Stapes surgery is really the last step when you're doing endoscopic middle ear surgery. It's also a bit of warning because it might not be so easy when you are doing it for the first time, or even if you have a little bit of experience, you can very well stick to the microscope for your Stapes surgery. I also did it that way, and with the growing experience, you can then start to do endoscopic Stapes surgery as well. So That said, I think we can start off with a clinical case. So this is a very recent patient of mine. She's 29 years old and has, as you can see, a mixed hearing loss on the right side. She never had any otological history. She has a tinnitus on the right side as well, but otherwise no complaint. Family history is negative. And yeah, well, she now complains about not hearing on the right side and having difficulties to localize the sound in the room. The other side you can see is normal. And I performed the CT scan. You can see here the CT scan. This is the mastoid. You can see the cochlea. And you can see in the vestibule, this is the stapes here, and you can see this sclerotic spot. You can see it on this slice, and also on this one. Facial nerve would be here. So there might be very subtle findings, but I think it's good to confirm your diagnosis and to rule out other causes like a third window or something like that using a CT scan. And so I offered her both options, and she decided to go for surgery. And this is her procedure, the endoscopic stapedotomy. And we can take a few minutes to see this really in detail. So we'll start off again with the infiltration. And you can see I go very, very slowly, a very slow infiltration into the posterior and superior part of the canal. Then the flap design. In the endoscopic approach, the flap is more superiorly based usually, but this is not exclusive. And you see I make an incision slightly anterior to the hammer here, and then I make the incision in the inferior part of the canal as well. And then we can do these two horizontal incision and make a vertical one thereafter. You also see no monopolar anymore. With growing experience, I left the monopolar away. I think you can do it very nicely with these cottonoids, with the topical adrenaline to control your bleeding. And so I don't use the monopolar anymore, also because it was not available for some time, so I had to cope with that. You see the neuropathy coming in, and we can dissect very, very slowly the flap. And now this is something I love about the endoscopic approach. You can see here, this is the posterior canaliculus of the chorda. So I already know where the chorda is. You can see here the annulus coming in. And this is something you might find quite hard if you're using the microscopic approach to really, really see this. You know it, you can feel it, but now you can really also see it. And now we can open up the mucosa of the middle ear. Here you can see below the annulus, we cut open the mucosa and we directly see the incudostapedial joint. And you can see we can put the flap a bit anteriorly, and we have a direct access to the middle ear. We can explore the mobility of the chain. Hammer is moving well. Incus also, and you can see here the stapes. We can move it and it's fixed. This is the stapedial tendon. Round window will be here. And now this is something very important also in the endoscopic approach. We need to make a bit of space. So we mobilize the chorda tympani slightly below this posterior lateral ligament of the hammer, and we can, with the curette, slightly enlarge our canal. This is something very important. In the endoscope, you can see very, very well, but it might not be so easy to reach down here the foot plate. So it's very important to make a bit of space in order to see very well. I usually say if you can reach the foot plate with a straight instrument, let's say your suction or any other straight instrument, then it's enough. And I usually use a curette. You can see here the curetting of the scutum. You can, depending on the case, I use the smaller or the larger curette, and in order to be able to remove a bit of this bone, and you can see the rotatory movement. Very, very important not to push on the bone, but to use your curette like an ice cream spoon. This is the way it works. It's the way it was designed. And you can see I turn around and then the bone comes off very easily. And I can make a bit of space in order to expose the facial nerve and also the pyramidal eminence. So I check again the movement, and now we can disarticulate. So I use a small hook, usually to open up the incudostapedial joint, and then you can section the joint with a movement going from the pyramidal eminence anteriorly. It's important because this way the tendon helps you to stabilize the whole ossicular chain. And now we can test again. Okay, moving well, very important, and not moving well is the stapes. Now I cut away the tendon, and with a small drill is a 0.6 micro drill and the osteostap micro drill. I drill away the posterior crus of the stapes. So you can see very well that it is drilling here, and also you have the haptic feedback. It's very nice because you can feel as soon as you are through. And then we can move the suprastructure, and look here, this is the stapedial tendon. And when I move the stapes, there is also movement here. You see, this is the stapedial reflex because of the stimulation of the inner ear. Here's the reflex. I think everybody saw it. And now I can fracture downwards the anterior crus. If it is very, very stable, sometimes I can also drill it or use the laser to cut it away, but this is very rarely necessary. And now you can see the anterior crus is fractured, and I can remove the suprastructure of the stapes. And now we have a good access to the foot plate. You can see here the foot plate. I take again the same micro drill, and now we can do the platinotomy. It's important to make it exactly below the articulation, and with the drill, no pressure, you can easily do the stapedotomy, the platinotomy, and to access the vestibule. And with a very fine suction, we can remove a bit of the bone dust in order to see very well the hole that we drilled. You can see nicely now the hole. You can see the spherical recess below your foot plate. And now it's time to put inside the prosthesis. Now, which size of prosthesis? Some colleagues would always put the same. You can measure here with this device, and you can see that the arm of the device was above the incus. You can see it here. And so it's a 4.25 prosthesis. And now you can see the mWING prosthesis coming in. In contrast to the microscopic approach, I usually just put it into the middle ear with using a suction, and then with the needle you can then put it into the right place. So you can see here it's already on the long process of the incus, and then we see it's not in the hole yet, so we can push it a little bit more inferiorly, and now it fits very nicely our platinotomy. And then we close the loop. This is a McGill forceps, and then we can close it around the long process of the incus. And you can see very nicely how the two wings here stabilize along, and a very nice attachment of the prosthesis to the long process of the incus. And with the endoscope, we can see at the same time very nicely that it moves good below. Okay, then we can place again the tympanomeatal flap into its position. And This is usually very straightforward, of course, because there is no disease in the middle ear and no disease in the canal. And you see there is no need for canaloplasty, even in this quite small external auditory canal. So we put back the flap, and I stopped to use a dressing, so you can leave it like that. I sometimes put a small gel foam into the canal, but there is no need for other dressings. After 2 weeks, I just make a small check of the patient, and this is the audiogram after now 2 months and 1 week, and you can see we have a very nice result, almost complete closure of the airborne gap, and I'm sure by the next the check in about 6 months, she will be fine with a complete closure of the airborne gap. Good. So if you want to train this kind of this is about the chorda tympani. This is one of the studies we did together with our friends from Italy, and you can see there is no real regarding the postoperative dysgeusia in this cohort of 48 patients. It does not depend on the chorda itself, on the anatomy of the chorda, but it might depend on the technique. So if you use a skeeter drill or a micro drill, as I did before, the osseous stub, you might have less dysgeusia than when you use a CO2 laser. This might be due to the heating of the chorda tympani. You also saw during the video that the chorda is not in the light of the endoscope all the time, so it's not drying. This is something you can sometimes see in the microscopic technique, that the chorda with the time gets a bit dry. This is about postoperative dysgeusia. You can see early dysgeusia and late dysgeusia. So there are always a few patients, when you ask them, who might complain about this, but most of our patients are without problems with the chorda tympani. And now it's when you want to train, I just would like to show you this small video. This is a model, an animal model. It's a sheep model for training of endoscopic stapedotomy. You can see there is still some bleeding in this model, but it's of course only because it was frozen before. These are frozen heads of sheep, and you can see you can perform very nicely all the steps, the tympanomeatal flap elevation. We go into the middle ear, and the anatomy actually is quite similar from the sheep to the human. Because you have also the 3 ossicles, although you see the incus is a bit different, the long process is much smaller, and you can see here the stapes below. Here I use a laser to perform stapedotomy. Here is the facial nerve, and in the end you can try to perform a stapedotomy and to position your prosthesis. This is just a small outlook into the training. If you do this several times, you can see here, even if you're not an expert surgeon, your surgical times might come down very nicely. It's about 10 times 10 repetitions of sheep stapedotomy, and you can see then you have quite a nice surgical time, and which comes quite comparable to the expert who has a stable curve all the time. Okay, so in conclusion, I think the endoscopic approach allows for very good and favorable results in Stapes surgery. I like the mWING prosthesis and its design because you can quickly place the prosthesis. It's very easy to crimp, and then you have a stable coupling due to the wings on the long process of the incus. And in my opinion, the endoscope by itself is a very beneficial tool in otology because you can see very well what you're doing. You can have a minimally invasive surgery and a very precise prosthesis placement. So if you're interested in learning a bit of endoscopic ear surgery, we do a course in Lausanne in October, and I would like to thank you very much for your attention.
Thank you very much, Lukas. Very, very interesting presentation. And I'm always impressed about the pictures that you get from the endoscope. It's really so nice to see the middle ear like this. So to the audience, if you have any questions, feel free to type them into the chat. I will use the time that you need to type your questions to ask my questions. So during the presentation, I was wondering, Lukas, do you remember your first endoscopic surgery?
The first surgery altogether, or
altogether? Yeah, not on the sheep, but in the human.
My first, yeah, of course, yeah.
What was it? Do you remember what it was?
It was a type 1 tympanoplasty.
Type 1 tympanoplasty. So exactly
type 1.
Also recommend to start with.
Yeah. So I think the most important thing, if you really want to start and you have no experience at all, I would recommend to use it first in the outpatient clinic. If you look at your patients for ear examination, this already gets you a bit of a feeling. And then grommet placement is a very good thing to do. Also, when you want to teach your residents, if you show them how to position the grommets, is always very good with the endoscope because they have the same view as you have. And then, yes, I think adult type 1 tympanoplasty with a posterior perforation and a wide canal, I think would be good. And of course, it's always good if you already have a bit of experience in models or in cadavers. If you do a bit of training before, I think it's always good to be prepared for your first case.
Yeah, preparation is always good. I agree. So because you only have one hand left, so to say, to handle the prosthesis as well, how much practice do you need for this to really be easy?
It's a very good question. I think I did my fellowship with Professor Presutti in Italy. And when I started to do Stapes surgery with the endoscope, I asked him, how long will it take to be really comfortable with this kind of surgery? Because it's something where the patient has no other problems than hearing loss, and you really want to improve the hearing. There are some risks associated with the surgery, although they are very, very rare. You don't want to have any complications, especially in the beginning. And I asked him how many will it take me to feel like you do, and he told me it will never happen. So it's always a bit special about about stapedotomy, but I think it's a surgery by itself. And to handle really easily the prosthesis, you can also say about PORP prosthesis or TORP prosthesis. It takes you perhaps about 20 cases to be really comfortable, because they might and also discover the small tricks in order to not have them everywhere. But if you look also the microscopic colleagues, most of the colleagues, they position the prosthesis also with one hand.
Yeah, with the suction,
And you
right?
really see that they use both hands to really put it inside. It's of course possible, and but usually it's also not really necessary, because especially in Stapes surgery, you have no bleeding, you have nothing to nothing that you want to hold away. So I would say most surgeons position it with one hand as well. The difference that you have with the microscope, usually you put it in one shot. No? You put it inside, took on the long process and also in the foot plate. And I think the microscope, this is very, it's good. It's well feasible because you have a depth perception, which you don't have in the endoscope. It's a 2D view. It's the same view. You have exactly the view that I showed you now in the video. So because I don't want to push on the foot plate once that I position the prosthesis, I just put it, and then I push it slowly, and it falls by itself into the hole. So this is something different for some, let's say, security or safety concerns for not pushing the foot plate into the vestibule.
Are there some cases where you still use or you prefer the microscope to the endoscope?
For Stapes?
No, always endoscope.
Well, yeah, I think from all the middle ear surgeries and all the benefits that you can have with the endoscope, I think stapes is really the where you have the least benefit because the
Mhm.
disease is very, very localized, and you just need to see this one piece of the middle ear. And I would say the results that there is not a big advantage for the endoscope. But if you're doing everything with the endoscope, then for me, it's of course it was logic that I also wanted to change, and because I feel very comfortable with the endoscope, I don't think that there is something where you can really benefit from the microscope. And I think if you have also difficult cases, malformations, or if you have revision surgery, the possibility to really see what you are doing and or what has been done before is much more, in my opinion, is more important than having a second hand to do a bit of suction.
Yeah.
The position also, if you have to do a malleolo vestibulopexy, it's very straightforward procedure with the
Mhm.
endoscope. Because
Okay.
again, there is not a lot of disease, not a lot of inflammation that might be bothersome.
Hmm. Okay. Thank you. I see we have a question in the chat from Tom Wilson. He asks, do you use local or general anesthesia? And do you seal the foot plate?
If I seal the foot plate,
Yeah.
yeah. So I use always general anesthesia. It's I do it. We have a protocol that we set up just very recently with a mask anesthesia. So it's very quick, and so it's always general anesthesia. I saw some local when I was a young, no, I was still a medical student. I saw some local and I saw the people vomiting on the table. So,
Oh.
not, in my opinion, I don't see much benefit, and the
Mhm.
people are doing fine after general as well. And about sealing, no, I don't seal the foot plate. I do a blood patch. So
Okay.
I scratch a little bit on the promontory, and then there is a little amount of blood around the foot plate. I
Mhm.
used to put some gel foam, but I stopped putting
Okay.
gel foam.
Why, if I may
Uh,
ask?
Sorry?
Why, if I may ask, did you stop with the child?
Why? Yeah,
Mhm.
because there is a very small risk of having like a granuloma or a reaction to the gel foam in the middle ear, and yeah, I always think if you don't need it, why do you
Do
need
it.
it? So
Mhm.
it's the same for the dressing. For years, I put always the dressing into the ear canal for stapes surgery, and I recently learned from colleagues that it's not necessary. And
Mhm.
then I thought, yeah, of course it's necessary. I always did like that.
Mhm.
Actually, it isn't. And I tried, and now I stopped to put dressing just for stapes surgery, of course.
Mhm.
If you have a big reconstruction of the middle ear, I still put dressing and everything very traditionally. But if I don't need to do it, then I leave it away. I think everything you do, which is not necessary, it might also be a source of error or complication. So keep
Mhm.
it simple.
Yeah. Yeah, and it's also a little bit, it goes back to the citation you had in the beginning, not fight the old, I cannot remember it exactly, but not fight the old, but be open to something new. Yeah.
Yeah, put your don't think about too much about what the others say. Let's say fight the
Mm.
old, but
Mm.
put your energy into the new technique.
Mhm.
I'm very open to. I like to go and see also other surgeons doing, and you can always it's always beneficial. And of course, perhaps we can say about the sealing if there is a stapedectomy or a part of the foot plate breaks and comes out, or if I have a gusher or
Mhm.
I have a very big hole, then I would put a bit of fat from the lobule in order to
Mhm.
seal. the hole is too big. But if you make a 0.6 millimeter hole and you put a 0.4 prosthesis into it, you have nothing or virtually nothing. So when the patient is in the evening of the surgery, I think that the hole is sealed by
Okay.
nature.
But you also don't make a very tight hole stapedotomy. So the stapedotomy is always, like you say, 0.2 millimeters larger than the piston itself, right?
Yeah. But it's 0.2 millimeter. It's
Yeah. No,
the hole itself is very, very small.
Yeah, but of course, it's also important that there's no friction between the piston and the stapedotomy. This is why, this is why.
Yeah, 0.2 I think is reasonable. 0.2 difference between the prosthesis and diameter, and the diameter of the hole is a reasonable way to go.
Okay, thanks. I see there's another question. Shirley Hausherr, she asked, do you use cortisone in the canal after or before opening the foot plate?
No.
No.
I don't give any steroids at all. I don't give steroids intravenously neither.
Would you see a reason?
If it's difficult and I have to manipulate more, which is quite rare, then sometimes I ask the anesthesiologist to give a dose of prednisone, but then I would give it intravenously, but no topical steroids, no.
Okay, good. Are there any more questions in the chat to the audience? Use the occasion to ask Lukas Anschütz. I mean, you talked a lot about what beginners can do when they want to start endoscopic surgery. I think this was also very important for many of the audience, for many people in the audience. And you also said that you organize courses. Are they usually well attended? Is it more younger surgeons that come, or are there also more advanced surgeons who want to learn the endoscopic approach?
Yeah, it's actually both. So we have it's always some kind of mix. So in my opinion, you don't need to be experienced surgeon, microscopic surgeon, in order to start with the endoscopy. It's something which goes at the same time. In my opinion. So we have really all kind of levels, and our program starts from the beginning of the tympanomeatal flap elevation to the lateral skull base. So then the beginner would perhaps spend a bit more time in the first steps, and the more expert surgeons then have more time for the more advanced procedures. We do also dedicated Stapes workshop with some artificial models which have a fixed foot plate, because in the cadaver it's very difficult to find a fixed foot plate, but which are very beautiful, where you can really learn to guide, to be very, very gentle to the foot plate in order to make these very, very precise movements. And yes, I think it's also because for that I spent a bit of time in saying what you should do to start off with the technique. I usually don't talk so much about Stapes surgery, on one hand because the endoscopic approach perhaps is not so much more beneficial than compared to other diseases, compared to cholesteatoma surgery, for instance. And it's important. I think it's important, and I'm repeating myself, that people don't start with a stapedotomy and have a bad experience just because they are not ready. I think it really is something you have to take your time, and once you are really proficient in endoscopic ear surgery by itself, then you can start off with the Stapes. Yeah. It's really, I don't think that you need to have 200 microscopic stapedotomy to then do the endoscopic one, but you need to be that everything, the flap and all the manipulation of the chorda and the use of the skeeter, that you are familiar to that, and then you can start with the stapedotomy.
Yeah. So I also really like the diagram that you showed with the, I think it was green in the center, purple, and then blue, right? Yeah, I think it shows very nicely to respect one's boundaries, but also be eager to learn and to broaden your horizons. I think it's very nice. Yeah, and I think, are there any more questions in the chat? No? I don't know. Lukas, do you want to say any final words to the audience?
No, well, thank you for attending. And well, if there are any questions by later on, don't hesitate to contact me.
Perfect. Okay, then I thank you very much, Lukas, for this very interesting presentation, for sharing your experience with us and also with the audience, of course. There will be another Surgery Online soon, and we don't have the date fixed yet, but of course we will keep you informed about any advances on finding the date, of course. Okay, thank you all very much. Thank you again, Lukas, and I wish you all a very nice rest of the day. Goodbye.
Thank you. Bye-bye.